Welcome to Webisode 21. I'm Dr. Sonia Longest, a board-certified physician in addiction medicine and psychiatry. I have been practicing in the addiction field for over 15 years, and I'm currently the Chief Medical Officer of the Walter B. Jones Center in Greenville, North Carolina. This webisode will focus on the 3 regional alcohol and drug abuse treatment centers, ADACs, operated by North Carolina Department of Health and Human Services. The ADACs are specifically designed to provide inpatient treatment, psychiatric stabilization, and medical detoxification for individuals with substance use and other co-occurring mental health diagnoses to prepare for ongoing community-based treatment and recovery. All 3 ADACs are certified as opioid treatment programs. All provide treatment at various levels of care that include ASAM 4.0 medically managed intensive inpatient services. Each ADAC also provides services for pregnant women, and Walter B. Jones High-Risk Perinatal Program provides services to women who are high risk from all across the state who are in their first, second, and third trimesters. Our services are designed to assist individuals who continue to have difficulty making sufficient clinical gains at a given level of care. For example, patients who continue to use opioids at dangerous levels despite adequate or high-dose escalation and intensive counseling, or individuals who may be abstinent of opioids but continue to use other substances that significantly impairs their functioning and recovery. Also, those individuals who may experience toxic effects of substance use, such as presenting to the clinic impaired, or who have experienced a recent non-fatal overdose. And then those who have potentially dangerous withdrawal symptoms that require medical detoxification and management, such as from alcohol and benzodiazepines. Other individuals to consider for admission are patients with significant mental health conditions or unstable, chaotic, and dangerous living situations that severely impacts their recovery and perpetuates their addiction and continued use, as well as anyone with an acute psychiatric emergency, suicidal ideation, homicidal ideation, or psychosis which may be related to substance use or as a primary co-occurring condition that requires inpatient stabilization. This includes individuals on an involuntary substance abuse or involuntary mental health commitment. Also consider high-risk inductions, which may be performed in an inpatient setting where there is continuous monitoring, especially for patients with certain co-occurring chronic or acute medical conditions, patients with excessive polysubstance use, or patients that require concurrent detox services, all of which place the patient at higher risk of overdose during the induction period. You may also want to consider inpatient induction for individuals who have had numerous prior unsuccessful outpatient treatment attempts, where early stabilization is key for outpatient retention and improved outcomes. Essentially, anyone that has a need for supervised medication management and that requires daily monitoring and support that cannot be safely provided in a lower level of care. The ADACs are an integral part of the continuum of care for people with substance use disorders. We provide additional supports and a higher level of medical management than what is available at an outpatient facility, and we strive to work with you in partnership to provide coordinated care. The ADACs offer an array of specialized programs to meet the complex needs of our shared population, and all use evidence-based and trauma-informed treatment modalities, including medications for opioid use disorder. The staff at the ADAC will work with your patients to help them attain an initial period of stability. While patients are in treatment, they will receive medical and rehabilitative services for as long as medically necessary to regain stabilization. The length of stay is variable and individualized. During their ADAC treatment experience, patients will receive specialized inpatient OTP services as well as evidence-based withdrawal management services, psychiatric, medical, and nursing services, and a wide variety of group therapies and individual counseling, as well as recreational therapy, family services, AA and NA meetings, and comprehensive discharge planning. As licensed opioid treatment programs, all facilities are able to begin the induction process for methadone or buprenorphine, and for individuals already on medication, it will be continued with dose adjustments as necessary to stabilize withdrawal symptoms and cravings. The 3 facilities are Walter B. Jones, R.J. Blackley, and Julian Keith, which serve the eastern, central, and western regions of the state respectively. Admission is available to anyone age 18 and older, regardless of financial resources or insurance status, and cost is based on an ability to pay sliding scale. All of our facilities are tobacco-free. Referrals are usually made through an OTP or other community provider, hospital or emergency department, mobile crisis, or the LME-MCO. Providers who wish to make a referral should use the State Facility Regional Referral Form, which can be found at the link here. In addition to the regional referral form, we also will request a letter of intent. The letter of intent confirms that you will accept an existing patient back to your clinic, accept a new patient to your clinic once stabilized on medication, and to transition the patient to another program if that is what is requested. Also, please include in the letter if the patient will be switching from methadone to buprenorphine or naltrexone or vice versa. Also, please include urine drug screens. These are used as a therapeutic tool. Dosing records on the day of admission are also required for review of recent dosing history, as well as to confirm the date of the last dose and dose strength. Please include any special circumstances or needs for us to consider in our treatment planning that will help us better tailor care to the individual patient. The referral form and accompanying information should be faxed to the ADACT admissions office. The admissions staff will contact the patient, discuss the expectations of treatment, what to bring, and coordinate an admission date. A smooth transition from inpatient to outpatient is also critical to a patient's success. Therefore, as soon as we anticipate a discharge date, a social worker or discharge planner will contact your program to coordinate care. We will not be able to provide take-home doses of methadone or buprenorphine. Therefore, we will need to discharge the patient directly to your clinic on a day that you can ensure the patient can resume or begin their medications and treatment without any disruption in their care. We will fax their dosing record, med reconciliation, continuing care plan, labs, and discharge summary. Now, we would like to share a common story to illustrate our successful partnerships with outpatient providers. An OTP had a patient who was pregnant and stable on methadone, but was struggling with cocaine use, illicit benzodiazepine use, depression, and PTSD. Her living situation was also not supportive of her recovery. So she sought treatment at an ADACT. While she was at the ADACT, she was able to attain an initial period of abstinence from cocaine use, receive medical withdrawal management from benzodiazepines, and stabilize on medication, which helped decrease her depression, anxiety, and improve her sleep. Through intensive evidence-based trauma-informed therapy, which included seeking safety, she learned initial skills to manage her mental health conditions. She received medical and obstetric care. She attended counseling groups, including relapse prevention, and then realized that she needed a safe, stable environment with longer-term supports. The staff at the ADACT worked with her to identify a women's perinatal and maternal residential substance use disorder treatment program that had availability. She interviewed, was accepted, and was able to enter the program upon discharge. Prior to the discharge, the ADACT coordinated with both the perinatal program and the patient's OTP to ensure that the patient went door to door from the ADACT to the perinatal residential program, and that she was able to continue her methadone at her OTP the following day without any disruption in her care. She stayed on her medications and in the perinatal program throughout her pregnancy and delivered a healthy baby 4 months later. After completing the residential program, she was able to move out on her own with her son. She continues with medication and is engaged in ongoing counseling with her OTP provider. A success story. So we are here to support you and your patients. Please contact our admissions office or chief medical officer of your ADACT if you have any questions of our processes and treatment, are in need of an immediate patient admission, or if you would just like to discuss a complex or challenging patient case. You can also reach out to the SOTA for assistance. Thank you for watching, and keep up the good work.